Good morning, everyone. Welcome to our event at Suncloud Health. I'm very excited to have you here. Just a little bit of housekeeping before we get started. You will need to be on the webinar for at least 60 minutes to receive CE credit. After the event, you'll receive an email from me at tgaster@galenmentalhealth.com with instructions on how to get your CME. If you have any questions or difficulties during the presentation, please feel free to reach out to me. I will type my email into the chat box for everybody. And I'm really excited to introduce you to Dr. Kim Dennis. She is our founder of Suncloud Health. Amazing wealth of knowledge. Every time I meet with her, I learn something new. So really excited to introduce you to Dr. Kim, and then Dr. Hammond will be joining us in a few minutes.
Thank you very much, Tammy, and thank you for all of your legwork to make our grand rounds happen and the CME and CE portions as well. I want to thank everybody for joining today, and I'm looking forward to a really exciting and very, very, very relevant talk today by one of the leading national and international experts on cannabis use disorder in adolescents. I'll tell you a little bit about Suncloud Health while we're trying to help Dr. Hammond get on to the Zoom. We offer residential treatment. We're based in the Chicagoland area. We have five to six locations, but 2 of those are residential treatment center units for adults, where we provide treatment for patients with substance and addictive related disorders, eating disorders, comorbid trauma and trauma-related disorders, as well as mood and anxiety disorders. We also treat food addiction, which is rare and definitely not well received by many of my colleagues in the eating disorder world. We have 3 PHP and IOP centers as well throughout the Chicagoland area, treating both adults and adolescents with, again, multimorbidity, complex psychiatric comorbidity, and substance use or eating disorders. Many of our patients come with 1, 2, 3, or 4 so-called primary diagnoses, but they truly do have multi-morbidity, more than comorbidity. We also have a program in Maryland, which offers outpatient services at this time, and we'll be offering intensive outpatient later in the fall. I am blessed to be able to work with a team of 9 other psychiatrists and psychiatric providers. We have a very psychiatrist-heavy staff at Suncloud, and I want to just take a moment to introduce you to Dr. Chevalier, Alex Chevalier, who is on the screen here as a panelist. Dr. Chevalier is our medical director for child and adolescent psychiatry. And he was trained at the University of Wisconsin and did his child and adolescent fellowship at the University of Illinois, Chicago. And Dr. Chevalier has been working with children and adolescents for the last 10 years and has really been focused on adolescents with substance use disorders and eating disorders and multimorbidity for the last 3 years, sort of 3, maybe 4. Time flies when you're having fun. So I'm grateful to have Dr. Chevalier and his expertise here on our staff, leading the way with our adolescent treatment program. And also Dr. Chevalier serves and knows Dr. Hammond through the ACAP, the American Academy of Child and Adolescent Psychiatry, Committee on Substance Use and Related Disorders in Youth. So we have grand rounds monthly, where we invite experts from all over the country. And if you go to our website, www.suncloudhealth.com, You can find past CME events that we have done, that experts across the country have done for us. And we have enduring continuing medical education and continuing education units that last for a year out from the time of the talk. So you'll find many different topics, some of them related to health inequities, some of them related to eating disorders, some of them child and adolescent specific, some of them substance use disorder specific. But those are available to you at no cost. And if anybody needs CEs or CMEs, I encourage you to check that out. That's www.suncloudhealth.com. Maybe while we're waiting, Dr. Chevalier, is there a patient that you're working with now that you can think of where this talk will be relevant? I know there are many adolescents with cannabis use disorder who come through our doors. But if there is a patient that you have in mind that you could share, again, in a de-identified way, obviously, just sort of like what this patient population tends to look like in the way of use and comorbidities. It might be a nice entree into the talk.
Sure. Of the substance use disorders we treat, cannabis use disorder is overwhelmingly the most common in adolescents, certainly in the modern era. It's pretty uncommon, in fact, for us to treat any adolescent that struggles with a substance use disorder that doesn't have cannabis use disorder. So certainly an area that we do a lot of work in. Of the patients that we're treating right now or have treated in more recent times, I think there's kind of a multitude of great examples to draw from. But one is an individual who is struggling with escalating cannabis use and whose family members, had significant concern about how that was impacting their life. Certainly at the age where they could be driving or going out with other individuals, who would also be using and potentially be driving. And so we're able to get started in treatment, being able to work, to have some more understanding about what was actually going on with the THC, what effect that was playing inside his brain, and how that could cause harm both in the short and long term. It's actually really impactful for this individual.
And what was the route of administration? What types of cannabis?
Yeah, like many of the youth that I see these days, that typically has a variety of routes of administration. Most of the people who are using will primarily be using vape pens. Those provide the highest concentrations of THC, typically in the 90 to 100% range these days, while providing that at the lowest cost. And it's also very easy to conceal, bring to places. Odor is present, but dissipates quickly and is relatively minor in comparison to the smoked plant matter. But typically, even if 90% of the overall milligrams of cannabis consumed are coming from vape pens, there's going to be some use of edible products in some situations, and then some use of joints, classic combusted plant matter of yore, like when I was a teenager, the only way that existed to consume cannabis. So we do see almost everybody will have multiple routes, but almost always the vape pen will be the most common due to pricing and convenience, I guess, would be the word that consumers would use.
And what sorts of quantities, right? Like,
yeah.
Yeah,
a lot. That's been the summary for most of the teenagers we're seeing. Big struggles. Not surprisingly, these substances dose response makes a big difference. And so individuals who, are passing a joint amongst 8 friends and taking a couple puffs are going to look a lot different than somebody who's got their own vape pen and has taken 5 hits from that multiple times a day. Typically, but not always, vape pens are sold in gram increments, oftentimes 1 gram, sometimes 2. So it's 1,000 milligrams. And again, typically these days running at 90 to 100% purity. Vaporized cannabis products also move into your bloodstream through the alveoli faster than the combustible plant does itself. And so the overall active number of milligrams coming in when individuals are using just ends up being very, very high as a result of the convenience and low cost associated with that. So it's a big process.
And for the example you brought up, how
Yeah.
quickly, how long did one vape pen last them?
Yeah, so for that individual, somewhere in between like 1 and 2 weeks would be a typical pattern for a pen. And so it's a really profound amount of substance. There's not like a 1-to-1 equivalence with alcohol that we can easily come up with, but certainly somebody who's consuming several alcoholic beverages a day to have a similar level of intoxication, and you're doing that at the price of about $35 for a dispensary grade vape, 1 gram around here. But folks who are going to Michigan can buy those sometimes on sale for as little as $10. Might get turned around and sold for 20 or 30 here, and it's still a dispensary grade. If you're taking one that's falling off the back truck from China, even with the higher premiums that adolescents pay, since they're not able to legally purchase it, pretty uncommon for people to be spending more than $20 or $30, and that's to be intoxicated most of the day, every day, for 7, 10, 14 days, which is, just again, it was an unheard of thing, I think, 10, 15, 20 years ago, for somebody to be high all the time for these kind of prices. Teenagers
and to go unnoticed.
And to go unnoticed, sure. Yeah.
To be able to do it in school, right?
Yep.
Anywhere.
Yep.
And what sort of psychiatric comorbidity? Because this is not just whopping amounts of THC, it's whopping amounts of THC on a developing adolescent brain.
Mm-hmm.
Right. So what sorts of executive functioning comorbidity, psychiatric comorbidity are you seeing?
As we see a lot of patients who present telling you that they haven't had any comorbidity associated with their use, but it's really interesting seeing teenagers on the other side, when they've been abstinent and have been off of substances and, are 30 days out, 45 days out, 60 days out. Almost universally hear discussions about, how much CRISPR.
Hi, everyone. Oops, sorry to interrupt you.
Go ahead.
Dr. Chevalier, just wanted to give you an update. We're not really sure what happened with his Zoom. It's an error on Zoom end. We're going to give it about 1 more minute, and then he's going to call in, and we'll forward the slides, and he will be able to do that. You just won't be able to see his face. So I would say 1 to 2 more minutes before we join. We apologize, everyone. You will get the full presentation, and if you have to jump off at the 60-minute mark, you'll still get the CE credit for this. So give me just 1 or 2 more minutes to take care of it. And
I was just going to say, I think
so. You were just saying cognitively, they're so much sharper, right? Which
almost
makes a lot of sense.
everybody will describe feeling like a brain fog kind of lifting. We typically see better concentration, better retaining of information, memory and recall, all improving, and in a relatively short amounts of time too. I know, folks are really worried about, when they're going to have that aha moment, and it doesn't take long, and it is pretty universal, particularly for the individuals, who are using on a daily basis, multiple hits from a concentrate of THC a day. It does not end up taking all that long to have some of that positive feedback. And it's a, really rewarding thing with THC because it lasts in the urine system so long. A lot of our patients will have levels in the thousands. And then as they go through treatment and as those levels get metabolized down, we always have a very exciting day when we first get our urine negative tox screen, and comes to hopefully a lot of fanfare and celebration. A lot of excited patients and family members associated with that too. And so that really long lingering nature of THC is just a lot different than a lot of the other substances that generate addiction does come with some pros and also some cons. But one of the nice things is when we get, you know, that kind of feeling of it being finally out of your system and finally being able to think and feel and experience the world. You know, that's a double-edged sword, of course, because some individuals find that like, oh man, I can really feel my feelings now and experience the world, and that has hard things in it too, and can be tough and overwhelming. But you know, nice to be a human and having that experience as well.
So while we figure out your screen, Dr. Hammond, first of all, welcome. I'm so delighted you are here. And I'm just going to read, you know, the big lines from your very long and very impressive bio. So Dr. Hammond is a triple board certified general psychiatrist, child and adolescent psychiatrist, addiction medicine physician, and an associate professor of psychiatry and behavioral sciences in the Division of Child and Adolescent Psychiatry at Johns Hopkins. He has secondary appointments in the Behavioral Pharmacology Research Unit, Department of Pediatrics, and Division of Adolescent Young Adult Medicine. He is extensively published on substance use and addictive disorders in youth and clinical best practices in this area. He serves as the Director of Co-occurring Disorders in Adolescent and Young Adults Clinical and Research Programs at Hopkins, and serves on the Youth Substance Abuse and Addiction Treatment Committees for two national medical organizations, the ACAP and the AAAP. And without further ado, I offer to all of you Dr. Hammond.
There we go.
And we have a video. Amazing.
Gosh, I am so sorry for all of these technology issues here, but excited to be here and excited to speak to everyone today. Cannabis use and related disorders in young people during the age of legalization. The slide shows my disclosures. I have no conflicts of interest related to this presentation and receive a bunch of grant support from the NIH and other foundations. And these are the educational learning objectives, which are kind of clunky, but really in sort of an outline form. This shows really sort of the outline or agenda of what I'm going to cover in my talk for the next about 45 minutes or so. So briefly, I'm going to touch on sort of four themes. I'm going to talk about, you know, what cannabis is, how does cannabis work in the body and in the brain, and how has cannabis changed over the past 15 to 20 years, and how it's really a different drug than it was back in the 60s, 70s, and 80s, and even early 90s. I'm going to touch on the empirical data on neurodevelopmental effects of cannabis and long-term health outcomes related to adolescent cannabis exposure. And then the latter half of my presentation, it's really going to be focused on screening, diagnosis, and evidence-based treatments for youth with cannabis use disorders. And so really jumping right in, what is cannabis? Unlike, for example, alcohol, when someone says, I use cannabis or I used cannabis, that can mean a lot of different things because cannabis is a plant that contains a number of different bioactive compounds. The federal government defines cannabis as a plant that contains cannabinoid compounds, and in particular is defined as containing greater than 0.3% Delta-9 THC by dry weight. Whereas a similar plant called hemp contains phyto or plant-based cannabinoids, but contains less than 0.3% Delta-9 THC. There are There have been discovered more than 60 different phytocannabinoids in cannabis and hemp plants with Δ9-THC and cannabidiol or CBD really being the most common constituents of cannabis plants. Δ9-THC is responsible for the high from using cannabis with potency increasing in recent years, and cannabidiol is a non-intoxicating phytocannabinoid that may reduce some of the undesirable effects from THC, and for which there's a lot of research into. There are also minor cannabinoids and other bioactive compounds, including terpenes, which have received a lot of interest recently. In terms of how phytocannabinoids exert their brain and behavioral effects, they act on an endogenous neurotransmitter system that's present in our brains and in our bodies, called the endogenous cannabinoid system, which is sort of analogous to opiates and the endogenous opioid system. With this slide, with the figure on the right showing the expression of human endocannabinoid system throughout the body and brain, and the figure on the left really showing the structural similarities of endogenous cannabinoids, anandamide and 2-AG, and the two main exogenous cannabinoids, THC and CBD. Cannabinoid 1 receptors are expressed really throughout the brain, with the absence of expression in the brainstem, but with the highest receptor densities in subcortical structures, including the striatum, the amygdala, the hippocampus, the hypothalamus, and then also in the cerebellum, with cannabinoid 2 receptors expressed in neuroglia and peripherally. In terms of the brain effects, at the circuit and at the brain region level, cannabinoid receptors are of high density in brain regions that are involved in decision making, reward and motivation, emotion processing and stress, and memory, learning, and coordination. And it's based upon cannabis's action on these receptors in these regions that we attribute the acute effects of cannabis ingestion and the chronic effects of cannabinoids on these psychological and cognitive functions. At the synaptic level, cannabinoid 1 receptors are expressed on presynaptic neuronal terminals, predominantly in glutamatergic, GABAergic, and dopaminergic neurotransmitter systems. And so really, this cannabinoid system modulates glutamate, GABA, and dopamine. Over the past 28 years, there have been just dramatic changes in the cannabis policy landscape. This slide shows that really, over the past 25 years, we've gone from one state passing medical cannabis legalization in 1995 to, as of this month, 38 states in the District of Columbia having passed medical cannabis laws, and 21 states in the District of Columbia having passed recreational cannabis laws in the United States. As statistics show, about half of Americans currently live in a jurisdiction where recreational cannabis is legal. These changes have really caused dramatic shifts in both societal perceptions, but also in how cannabis has been promoted in the media, in its access, and in product types. It's really, over the past 20 years, we've seen just an expanding multi-billion-dollar cannabis industry, and then a hemp-derived cannabinoid product industry that are really running in parallel and regulated through sort of different regulatory mechanisms. There's been mass medicalization, or sort of the framing of cannabis as medicine. and a lot of technology has been really brought to bear on designing new ways of administering and consuming cannabis, and sort of designing new cannabis products and increasing access. And so, there's also been a significant amount of media promotion and advertising. And at this same time period, cannabis as a product has changed, with the average smoked cannabis flower that is consumed having tripled in Δ9-THC potency over the past 20 years. And with regard to the CBD potency, which is the line in orange in the center, if we're to believe that that's the driver of really the medical cannabis industry, at least the potency of cannabis products isn't showing us that, because the rates of CBD have decreased or been stable really during that same time window. Cannabis use is really the main one of the main drugs of abuse by young people. It's the main federally illicit drug used by U.S. adolescents and young adults, and rates and methods of use have changed in the past decade, with vaping increasing significantly among adolescents in recent years and past years, as shown on the figure on the left-hand side from the Monitoring the Future study, and with past year, past month, and daily cannabis use rates at historic highs in young adults and college students, as reflected in the figure on the right. Regarding cannabis use disorders, cannabis use disorder is the #1 substance-related disorder that U.S. teens receive treatment for, with 40% of cannabis use disorder admissions being in people under 20 years of age. Medical cannabis programs have also blown up around the country. I think it's important for me to just highlight this, that use of medical cannabis in pediatric populations is controversial, but the way these laws are written, children and adolescents can obtain medical cannabis with a parent's written permission, and in states with medical legalization, cannabis is being recommended and cards obtained and used for childhood mental health conditions, including depression and anxiety, ADHD, autism, bipolar disorder, with really no scientific evidence supporting this practice. And in fact, some scientific evidence supporting that cannabis is associated with worse outcomes related to some of these conditions. In terms of potential health benefits from cannabinoids, to date, the only childhood onset medical condition that cannabinoid-based medications have shown efficacy for are related to pharmaceutical grade CBD compounds or CBD medicines for childhood epilepsy conditions, specifically Lennox-Gastaut syndrome and Dravet syndrome, which are two rare genetic childhood onset seizure disorders that account for, that have a population prevalence of less than 0.007% of the U.S. population. And so it's not individuals with these conditions that are driving this medical cannabis industry for the most part. Cannabidiol supplements have also exploded across the country, and I've shown at the bottom of this slide just the different types of cannabidiol products that are available, from everywhere from sort of Walmart to your corner drugstore to the dispensary. And cannabidiol is infused in foods and drinks and even shampoo nowadays. The health benefits that are promoted in the popular media way outpace where the science is at with regard to this. I do believe that CBD may have some benefits for certain psychiatric conditions, and there are multiple clinical trials being conducted at this point in time. I think there's more than 20 listed on clinicaltrials.gov at this point in time. But really at the present, there's limited safety and efficacy data, especially in pediatric populations, and there's no guidelines for how to administer, for dosing and monitoring. And furthermore, There have been a number of studies showing that CBD and other hemp-derived cannabinoid products that are available on the market may have contaminants, may be mislabeled, and actually contain large amounts of THC that can make you intoxicated, and are not what's been tested in these clinical trials, which have predominantly tested pharmaceutical-grade CBD medicines, not CBD supplements from the supplement industry. And so I tend to recommend against using cannabidiol products in our patient population because just the data doesn't exist yet. And so in this era of cannabis legalization, there have been multiple changes in cannabis-related attitudes and use patterns in U.S. youth and in their parents that have really sort of impacted our healthcare landscape, and that play out in the conversations that we have with youth patients and their parents. This slide just shows sort of a number of the changes here: increases in use, regular use, and use disorders among adults with teen offspring, increased availability and access of various different cannabis product types by U.S. youth, a change in the types of products used, the sourcing of products. A lot of youth are diverting cannabis from dispensaries, the methods of using, and polycannabis use, with the average young person who uses cannabis regularly being a polycannabis user that uses in multiple ways, maybe vapes, smokes flower, and also takes edibles occasionally. There's been a dramatic increase in the vaping of both THC, CBD, but then also these synthetic THC analogs or mimetics, including Delta-8 and Delta-10, which are derived from hemp-based products and then sort of marketed underground as a legal way to get high. And there's also been an increase in the use of cannabis concentrates among U.S. youth. All of these, aside from the CBD being sort of higher concentration THC products that may be associated with worse outcomes in this population. Rates of past year and regular cannabis use among young adults in America have reached their highest level since the 70s. And so we're seeing a dramatic increase in population level use here. And at the same time, this sort of tracks with a reduction in the perception that cannabis is harmful to one's health, which has reached all-time lows across every age group in America since that data started being collected in the 1970s. And then lastly, for cannabis-related health outcomes, cannabis-related poisonings, emergency department visits, hospital admissions, and motor vehicle crashes related to cannabis have all increased in this age group. My research team has, in the past few years, also begun to focus on the effects of cannabis policy in particular. And this slide shows the results of a systematic review and meta-analysis that was recently published in the Journal of American Academy of Child and Adolescent Psychiatry, with the lead author, a junior faculty who works in my group, Aditya Pawar, finding that medical cannabis legalization was not associated with a change in population level cannabis use among adolescents and young adults, but recreational cannabis legalization was associated with population level increases among both adolescents and young adults. Our group is also interested in the downstream health effects of regular cannabis use and of cannabis legalization. And there's a number of studies that show that cannabis use is associated with higher rates of suicidal ideations and suicide attempts in young people. And so we sought to determine if legalization was associated with higher suicide rates in young people. And to do this, we used national mortality data from the CDD and CDC and controlled for individual and state level covariates. We recently published this finding, the results showing that both medical and recreational cannabis legalization were associated with increased suicide rates in female adolescents and young adults, and also in 14 to 16-year-olds of both sexes. We also found racial and ethnic differences in the effects of legalization on youth health outcomes, with Hispanic youth and Asian youth having higher suicide-related mortality if they lived in states that had legalized cannabis for medical or recreational purposes. Our group is conducting a number of other studies trying to determine why these associations are present, what are the mechanisms or pathways that drive this, and what other public health outcomes legalization has been associated with, and seek to use this information to really guide evidence-informed policy reform. For the next portion of my presentation, I'm going to touch on neurodevelopmental effects and long-term health outcomes related to adolescent cannabis exposure, and really sort of what the literature shows right now. While really an in-depth examination into cannabis's effects on brain development is beyond the scope of my presentation, there are a few points that I think are relevant to make here. First, that adolescence is a sort of sensitive developmental period. Adolescents' brains are still developing, this developmental stage makes them both more vulnerable to cannabis exposure and more likely to seek out and use and experiment with cannabis. The figure on the right-hand side showing the three different brains really shows how brain maturation changes from childhood to adolescence and to adulthood. And adolescence represents a period of development where the imbalance between an immature prefrontal cortex that is associated with less self-regulatory capacity and a mature and hyperactive reward and emotion processing brain system peaks at this adolescent time period and maps onto a time window where young people are more sensation-seeking and more likely to seek out and at least experiment with or try alcohol and drugs. At the same time, with the figure on the left here showing the expression of cannabinoid 1 receptors throughout the brain, these brain regions that are maturing also are the brain regions that cannabis is acting on to produce its behavioral effects. And cannabis's action on these brain regions alters development over time and can be associated with poorer outcomes as a result of this. The animal literature clearly shows a clear and consistent association between adolescent cannabis exposure, both in rodents and primates, and changes in brain structure and brain function that are associated with long-term cognitive impairment and a more anxious, depressive phenotype in adulthood. This slide really summarizes the human literature on the effects of adolescent cannabis use on short and long-term brain function and structural outcomes. My group has contributed to this work both with regard to EEG and MRI research. And really to sort of to summarize, there's inconsistent evidence for the effects in humans of adolescent cannabis exposure on brain volume, but there is growing evidence for the effects of adolescent cannabis use on white matter structure, which is really the scaffolding and the insulation of the neurons that improve the efficiency of how neuronal signal is transmitted, and also has shown is associated with altered electrocortical activity and cerebral blood flow, both at rest and during cognitive and emotional tasks, with these effects being larger and more consistent with an earlier age of onset and with chronic use during adolescence. My group recently published findings from really the largest systematic review and meta-analysis conducted on youth cannabis use to date. We included data from 45 functional magnetic resonance imaging studies that included approximately 3,000 cannabis-using and non-using youth. And our results showed that cannabis-using adolescents had altered brain function in prefrontal cortical regions during executive control, social and emotional processing, and reward processing, with these functional differences being larger when the sample was restricted to adolescents who met diagnostic criteria for a cannabis use disorder, as shown in Figure 1. And the magnitude of these functional alterations tracked with the severity, the number of cannabis use disorder diagnostic criteria, and were also correlated differentially with abstinence and related to treatment response in this population. And we're doing more work in this space. A major question in the field of cannabinoid research is, again, I mentioned at the beginning when I said, what is cannabis? Cannabis is a bunch of different compounds. And so how do the effects of CBD differ from that of THC? And how do they interact when co-administered? None of this research has been conducted to date in adolescent populations, but we can draw some understanding from the adult literature, with the adult literature showing that that there are distinct neurobehavioral effects of THC and CBD administration in adults, particularly on symptoms of anxiety, arousal, and psychotic symptoms. And THC and CBD pharmacochallenge fMRI studies show at times opposing and different effects of THC and CBD on brain function in adults. The figure on the far right of this slide shows findings from a study in adults that found that CBD was protective against THC-related hippocampal atrophy in adults who used marijuana on a daily basis. There's more and more interest in this idea of CBD as a harm reduction agent to reduce the likelihood of experiencing THC-associated adverse outcomes in cannabis-using young people. While I think that research is extremely important, I do think it's premature for us to say, let's give CBD to young people and let's broadly promote CBD use in this population, as there are also studies showing that CBD can amplify some of THC's effects, and data in both human clinical CBD studies and in animal studies do show some developmental adverse effects related to CBD that need to be better understood before we move forward in recommending CBD-based products for young people. In shifting to psychosocial outcomes, there's really convergent evidence from more than 10 longitudinal studies that have been conducted in countries around the world, including the United States, Europe, and Australia and New Zealand, although predominantly in non-Hispanic white populations. These studies have shown very clearly a signal that in a dose-dependent manner, adolescent cannabis use is associated with poorer academic and occupational or vocational achievement, impaired cognition, and worse psychiatric and substance use outcomes. With these associations remaining significant even after controlling for socioeconomic status and some social determinants, race and ethnicity, and premorbid mental health conditions. In adolescents who have mental health disorders, cannabis use is associated with worsened course of psychotic mood, anxiety, and anxiety disorders. And there's growing data showing that both in youth with mood disorders and without mood disorders, that cannabis use is associated with increased suicidal ideations and suicide attempts. And my group is seeking to better understand those associations. Interestingly, in individuals who started using cannabis during adulthood, while their recreational cannabis use is still associated with poorer health outcomes, they may experience fewer of these adverse effects. Although the young adult population also experiences more negative psychosocial outcomes. My group's extended the findings from adolescents to a young adult sample here from this study, which was a population level study looking at the health correlates of past 30-day cannabis use in a sample of over 40,000 North American college students. There are some factors that contribute to the likelihood of a young person who uses cannabis having adverse health outcomes. One of those factors is the age of onset and the age of onset of regular use. Earlier onset of cannabis use increases the risk later in life for multiple, for almost all negative health outcomes related to cannabis. I highlight at the bottom, data sort of clearly shows that about 1 out of 6 teens compared to 1 out of 10 adults who try cannabis more than a few times will develop a cannabis use disorder. And so really, I use the slide to highlight that this importance of trying to delay to prevent cannabis initiation during adolescence and to delay the onset of experimentation in this population. And by doing this, we can potentially reduce risk. The potency of cannabis and the amount of THC in cannabis products consumed both acutely and over time also matter for adverse effects related to adolescent cannabis exposure, with cannabis use being with a higher potency THC cannabis product use being associated with higher rates of depression, worse depression and anxiety symptoms, and then increased risk for that young person to develop a cannabis use disorder, and also increased risk for that young person developing a psychotic disorder. Again, in this developing sample, there seem to be these dose response effects that sort of are additive across age of onset, potency, and frequency. And so as an example for psychotic disorders, in the largest study conducted looking at cannabis use and psychotic disorders, this was in a European sample by Deforti and colleagues. They found that that individuals with early onset cannabis use before the age of 16 who used on a daily or near daily basis and used high THC potency cannabis products had a 6-fold higher odds of developing a psychotic disorder by young adulthood compared to those individuals who didn't use cannabis at all. And so for the last third of my presentation, I'm going to really touch on screening, diagnosis, relevant prognostic features, and then I'll touch on evidence-based practices. With regard to really identifying young people who use cannabis, I think it's important to really pull back to sort of what's good population health or sort of public health level practices for screening and managing young people with substance use in general. And really where the strongest evidence base exists for this right now is in a public health framework called SBIRT, which stands for Screening, Brief Intervention, and Referral to Treatment. SBIRT's an integrated public health framework focused on screening all adolescents in a specific population space and risk stratifying those adolescents across a continuum of substance use risk and delivering prevention, early intervention within the clinic setting, and then referring those youth that have more severe substance use or cannabis use disorders to specialty treatment. SBIRT is recommended by the American Academy of Pediatrics and SAMHSA and has really been highly promoted. And some of the research I do focuses on SBIRT. The screening portion of SBIRT, which I think is relevant here, there are a number of effective tools available for healthcare providers and prevention professionals for screening, and I show those tools here. None of them are specific to cannabis use, although the S2BI, which I highlighted there, and a number of these will ask specific questions about cannabis use. And in youth who screen positive for cannabis use, it's important to do a more comprehensive assessment where you're assessing their frequency of use, their methods and modes of use, and assess for diagnostic criteria for a cannabis use disorder. To obtain a DSM-5 diagnosis of cannabis use disorder, a patient needs to experience 2 out of these 11 symptoms within the past year. These symptoms include tolerance, withdrawal, including the experience of a cannabis withdrawal symptom, or using to reduce withdrawal symptoms, using larger amounts over time and spending a significant amount of time seeking out, using, and then recovering from cannabis use, making unsuccessful attempts to cut down, neglecting major roles, decreasing important activities, experiencing interpersonal problems and physical and mental health problems related to the cannabis use, using in hazardous settings like driving while high, and then also craving. Cannabis withdrawal, which is both a symptom of cannabis use disorder and a syndrome unto itself, is common and a clinically relevant phenomenon in this population that's experienced by more than half of heavy cannabis using youth, with more severe withdrawal symptoms associated with worse prognosis. There are subgroups that experience withdrawal to a greater degree than others, including frequent, really heavy cannabis users, female youth, and also youth with psychiatric comorbidities experience more severe withdrawal and more withdrawal symptoms for longer periods of time. And the slide shows the DSM-5 criteria for cannabis withdrawal symptoms. Co-occurring or comorbid psychiatric disorders are another clinically relevant factor for the treatment of youth with cannabis use disorders, and really represent the norm rather than the exception in this youth population who use cannabis regularly or who meet criteria for a cannabis use disorder. I've listed the most common co-occurring disorders on the left-hand side of this slide and their prevalence in populations of youth presenting for cannabis use treatment. As you can see from here, conduct disorder and ADHD externalizing disorders, and then major depression and anxiety disorders, and then also PTSD and trauma reactivity are among the most common comorbidities in this population. Bipolar disorder and psychosis are also highly comorbid here, and in populations that are identified based upon having bipolar disorder or having a psychotic disorder. Individuals with those conditions, about half of them will, for both bipolar and psychotic disorders, will meet criteria for a cannabis use disorder. And cannabis use makes the course of those disorders worse over time. This is probably one of the most important slides of my presentation, and so I wanted to really emphasize this. In adolescents and in young adults, across studies, what the data has shown is that stopping cannabis, treating cannabis use, and abstinence from cannabis is associated with improvements in depression, improvements in anxiety, and improvements in some of the cognitive deficits that we see in adolescents who use marijuana regularly, with improvements in depression, anxiety, and cognition emerging between 2 and 3 weeks after stopping cannabis use, after you get outside of that major withdrawal syndrome window. And really data from my group and others clearly show that cannabis use and psychiatric symptoms, in this slide, depressive symptoms, track together, with a reduction in cannabis use being associated with a reduction in depression in youth receiving cannabis use disorder treatment. And that getting youth who have a cannabis use disorder to cut down or stop their cannabis use is associated with an enduring effect after treatment on them having lower depressive symptoms over time. And so lastly, I'm just going to present a few slides on really effective evidence-based practices for treating this population. At the present, there's strong evidence to support the use of psychosocial therapeutic interventions, behavioral therapies, and psychosocial therapies as really the first-line treatments for adolescents with cannabis use disorders. The table that is shown on the right-hand side of this slide shows different behavioral interventions that have a strong empirical support for treating adolescent substance use disorders, including cannabis use disorders. The main evidence-based interventions include motivational interviewing, which is a brief intervention designed to really increase motivation to change behavior in this population, cognitive behavioral therapy, which uses skills training to target enhancing motivation, coping with craving, and dealing with high-risk situations, family-based therapies, which are focused on enhancing family communication skills, parent-teen relationships, and reducing conflict and negative interactions, and improving parental monitoring. And then ACRA, which stands for Adolescent Community Reinforcement, which is a community-based reinforcement approach. This shows the different mechanisms through which these evidence-based psychosocial treatments seem to exert their effect in this population. These tend to be treatment intermediate targets. While I present this, it's these interventions typically have a moderate effect on reducing cannabis and reducing relapse among young people, although long-term abstinence rates in this population are generally low and decline after treatment. And so there's significant room for improvement even with these sort of gold standard interventions. And so where our field is really focused on more recently is a few different pathways. How do we enhance and augment these, and can we do a better job of personalizing intervention? And so one question is, can treatment matching improve outcomes for young people with cannabis use disorders? And this slide shows the results of a large clinical trial comparing really the two strongest evidence-based behavioral interventions, cognitive behavioral therapy and family-based therapy for adolescent cannabis use disorders. So they compared these two over a 6-month treatment interval and then looked at a 12-month follow-up in 109 adolescents. And they found, as other studies have found and as meta-analyses have shown us, that on average, family-based therapy and cognitive behavioral therapy tend to be equally effective in reducing cannabis use in adolescents with cannabis use disorders. But they also found that there was a moderating effect of age and psychiatric comorbidity that may inform treatment matching. Specifically, they found that older adolescents and adolescents with fewer or with no psychiatric comorbidities showed greater benefit from the cognitive behavioral therapy, and younger adolescents and adolescents with more psychiatric symptoms and comorbidities benefited more from the family therapy approach. Other adjunctive interventions that have been shown to improve outcome among young people are adding adjunctive contingency management. Now, contingency management is a reinforcement-based behavioral intervention whereby you provide the young person an immediate reinforcer or reward for the behavior that you're trying to shape. And so for individuals with substance use disorders, this typically involves collecting point-of-care urine drug testing and rewarding the adolescent with like a $5 gift card to Amazon for a negative urine drug test at that appointment. What has been shown with this is that voucher or based contingency management is an effective modality for improving abstinence in adults with substance use disorders. It can easily be incorporated with other interventions. And in adolescents with cannabis use disorders, I show one study here, but this has been replicated now in 3 different studies. It increases the efficacy and the durability of cognitive behavioral therapy by about 20% in this population. And so this is something that I think is something that's beneficial, but we're still trying to figure out how it can be operationalized in sort of real-world clinic settings. Another strategy that is associated with improving outcomes is treating comorbid or co-occurring psychiatric disorders in youth with cannabis use disorders. And really, there's 20 years of good data showing that integrated and concurrent substance use and mental health treatment is associated with better health outcomes. In my clinical programs and in other programs, we recommend sort of thoughtful diagnosis and then targeting common symptoms with interventions. And I include an evidence-based resource guide from SAMHSA that I edited that was recently published 2 years ago. The last question that I'll address is really the question of, is there a role for medication in youth cannabis use disorder treatment? And for cannabis use disorder treatment in general. And this is based upon really sort of the field of addiction medicine. Pharmacotherapies have been used to augment psychosocial intervention for tobacco, alcohol, and opiate use disorders and improve outcomes in all of those populations. But really, to date, there are no FDA-approved medications for the treatment of cannabis use disorders in adults or adolescents. But there's been a lot of research in this space, and there are a number of strategies for off-label use of medications for both adults and youth with cannabis use disorders. And these have sought to target withdrawal, relapse prevention, and co-occurring psychiatric disorders, with most of the youth data focusing on relapse prevention and co-occurring disorders. This table really presents a list of the psychotropic medications that have been studied in randomized controlled trials for the treatment of cannabis use disorders in adults and adolescents, with the table in green on the left showing medications with positive primary outcome results from these studies, and the table on the right in orange showing negative primary outcomes. The sort of commonalities across the medications that have shown positive primary outcomes is that they seem to target cannabinoid, GABAergic, or glutamatergic systems, but really more work is needed in this space. And then, so for my final few slides, I'm just going to briefly touch on some of the specific findings in adolescents. To date, there have been no medication trials examining cannabis withdrawal treatment in adolescents. But despite this lack of evidence, given the prognostic significance of cannabis withdrawal in young people, I think it's important to just briefly summarize findings from the adult literature. And in the adult literature across studies in adults with cannabis use disorders, there's moderate evidence that cannabinoid agonists, gabapentin, and lofexidine, an alpha-2 agonist, may reduce withdrawal symptoms. Additionally, some small studies have shown preliminary evidence for quetiapine, zolpidem, and mirtazapine to improve cannabis withdrawal-related sleep disruption. And again, to note, it's not known whether these medications are effective in adolescents with cannabis use disorders. Although anecdotally, I will, in some of my patients, use a gabapentin taper, or use quetiapine or mirtazapine in young people with a cannabis use disorder, but also with co-occurring psychiatric conditions. This slide shows medication trials for relapse prevention in adolescent cannabis use disorder that have been conducted to date. So far, 4 studies have been conducted examining the efficacy of 2 mechanistically distinct medications, topiramate, which is a anti-epileptic medication that acts on GABA and glutamate and sodium and calcium channels, and N-acetylcysteine, which is a cysteine prodrug and a cysteine glutamate exchanger that modulates glutamatergic tone, but also is used as a antioxidant that protects against oxidative stress during Tylenol overdoses in young people. Just to touch briefly, the topiramate study, which I'm not going to go into too much detail on, that study found that topiramate was poorly tolerated compared to placebo, but did find a reduction in the amount of cannabis, but not the frequency of cannabis in adolescents with cannabis use disorders in the one controlled trial. The N-acetylcysteine data is stronger and more promising, and so I'm going to spend a little bit more time on it, although most of it's been conducted by my colleague Kevin Gray out of Medical University of South Carolina. And so after conducting a small open label pilot study that showed early signs of efficacy, Kevin conducted a double-blind, placebo-controlled, randomized controlled trial of N-acetylcysteine for cannabis use disorders. It was an 8-week trial and used a dose of 1,200 milligrams BID, with all of the youth receiving weekly behavioral counseling and also contingency management. And they looked at the primary efficacy outcome of the odds of a negative urine cannabis test during treatment. This slide shows the primary efficacy outcomes for this study, with the blue line showing the NAC or N-acetylcysteine group, and the tan line showing placebo. And what they found was that youth randomized to N-acetylcysteine had a 2.4 greater odds of having a negative urine cannabis test during and after treatment compared to the placebo group. Given the promising findings from that study, the National Institute on Drug Abuse decided to conduct a larger multi-site study to test the effects of N-acetylcysteine, not in adolescents, but in an adult sample of cannabis use disorder patients. And they really used the same exact dose and trial design. And interestingly, the results from this study, which are shown here, show that N-acetylcysteine in adults with cannabis use disorders had no effect. The odds ratio was 1 for N-acetylcysteine compared to placebo randomization. But sort of the interesting aspect of this is that that the group also conducted a sort of a post hoc subgroup analysis, pulling out the young adults between the ages of 18 and 21 and comparing them to adults over the age of 21. And they found that those young adults had a 2-fold higher odds of having a negative urine cannabis test if they were randomized to N-acetylcysteine compared to placebo. Whereas the adults older than 21 had no difference. And so, again, this now is results from both an open label pilot, a randomized controlled trial, and this post hoc analysis, all sort of converging on this potential developmental effect of N-acetylcysteine as a treatment for adolescent cannabis use disorder. And so what's the current thinking about it? So really, in summary, N-acetylcysteine is the only pharmacotherapy with a positive published intention to treat clinical trial abstinence findings for youth cannabis use disorder. And the data suggests that it's safe, well tolerated, and may improve cannabis abstinence by targeting compulsive drug-seeking behavior in this population. I show sort of the details on strategic use, dosage, and duration of treatment below. And then lastly, I'm just going to touch briefly from some trials have also examined medications for the treatment of psychiatric comorbidity within the context of youth having a cannabis use disorder. These have really been 2 studies, one focused on depression and the other focused on ADHD. Really both studies showed sort of a similar pattern where the medication versus the placebo arms did not differentiate, but youth who, but mood symptoms, ADHD symptoms, and cannabis use tracked together, and youth whose depressive symptoms or ADHD symptoms remitted or decreased during treatment had a reduction in cannabis use, and those whose symptoms didn't remit or decrease did not. Collectively, this suggests that we really should be aggressively co-targeting psychiatric comorbidity in this population, and that through co-targeting that we may get better outcomes. And so really, this slide shows the conclusions. I have just a few points and then I'll be done. Adolescent cannabis use disorders are an important public health problem, and the patterns of cannabis use are changing in U.S. youth during this age of legalization. Early exposure to cannabis, in particular high THC potency cannabis products during adolescence, is associated with adverse psychosocial and health outcomes. With regard to cannabinoid medicines, beyond childhood epilepsy, more research is needed to clarify the role of CBD and other non-THC cannabinoids for treating pediatric psychiatric conditions or for mitigating THC-induced adverse health outcomes before we could, we would start recommending these products for pediatric patients. And then from a treatment and diagnosis standpoint, psychosocial treatments, in particular, motivational interviewing, cognitive behavioral therapy, and family-based therapies are the first-line interventions for cannabis use disorders. And then lastly, there's emerging evidence suggesting that abstinence outcomes following psychosocial treatment for youth cannabis use disorder may be improved by adding adjunctive contingency management, aggressively treating comorbid psychiatric disorders, and really through targeted medication treatment, particularly for relapse prevention with N-acetylcysteine or for comorbid ADHD or MDD in youth whose ADHD or depressive symptoms don't improve with psychosocial treatment alone. And so I'll end there, and then this slide just shows the all of the different people that I collaborate and work with to do the work that I do. And so I'll stop there, and I appreciate everyone staying on. I hope my presentation was helpful, and I'm excited to to see if there's any discussion or time for questions.
Definitely. Thank you so much. That was just chock full of such important and relevant information, certainly to the work that we do here at Suncloud, but I mean, just a public health problem, right? In the context of an adolescent mental health crisis. So we'll do a couple of the questions, and then I have a couple, and I believe Dr. Chevalier probably has a couple too. So this one is from one of the attendees. Have you or the research seen any impact on whether the parents use cannabis, such as adolescents are more or less likely to relapse based on parents' use, or more or less likely in the first place to use based on parents' use?
So I'll say that that's an area of significant interest by my group and others in this treatment space, and some research that really is now like 15 years old shows pretty clearly that parents who use cannabis, their adolescents are more likely to try using cannabis and to develop cannabis problems. Anecdotally, I've seen this expand dramatically, and it's been a kind of a complicated dance that I hope my presentation accentuated this, the complexity of screening a young person for cannabis use, and you also need to sort of screen, are there parents that are using cannabis in the house, or do parents have a medical cannabis card, and what's their perception of youth cannabis? And so it speaks to the need to take a sort of a family-centered approach to address this issue in today's world, because I end up having to do a lot of work with parents who maybe have a medical cannabis card and are giving their young person their cannabis, or their young person is sneaking and stealing their cannabis from them and using it, and working with them around sort of resetting limits, and it's more difficult in the world today where so much public messaging is this is helpful for mental health conditions, which goes in the face of the science.
Right. Along the lines of the public messaging and policy interventions, right? It seems as though there's a huge need for, or potentially failure of, the medical community to really lead the voice of what the science shows. For example, states with medical legalization of cannabis for adolescents with mental health problems being listed as, legal in the state of whatever for treating an adolescent with depression, for example. Parents have no idea that means that the state legislature thinks that this is a good idea. I think parents assume when they hear medical marijuana, and this is a condition listed in our state, it must mean that doctors have approved this. From your perspective and a public health perspective, what are the areas, public messaging wise, for the medical field that we need to do better? And what in your opinion has interfered with that or blocks that?
I mean, I think that there are multiple factors that have contributed to sort of why we are in the position we're at right now. And some of this is that state legislatures have put up for referendum whether cannabis is a medicine, and then there's an entire marijuana industry that spends lobbyist dollars that summatively are more than tenfold higher than all of the mental health lobbyist dollars combined at any given year. And so it's just, there's a lot of money going into pushing our politicians in this direction, and the popular media and news channels have to some extent presented this in more of a biased fashion, which I think has complicated it as well. In terms of the role of medical societies and medical providers, I do think that we've both been sort of actively kept out of the room with the providers who are on board being sort of yes people, but it's also we've also not done enough as our medical societies to kind of push back and say this doesn't make sense, and it presents an extremely confusing picture that you have, and it sort of speaks to, in every state that has these medical cannabis programs, that it's somewhere fewer than like 3% of doctors in any state that actually will recommend medical cannabis and participate in these programs. And it's how do you reconcile that they, what criteria do those doctors apply to making a recommendation that that a young adult should get a medical cannabis card? And the young adults that I treat, it's who get a medical cannabis card, they're receiving completely opposing conversations with that doctor and with me related to what we recommend doing. And these states also that have set up medical cannabis programs, it's loosely regulated, not closely monitored, and there aren't mechanisms in place to, for example, de-prescribe medical cannabis in a patient who's had an adverse outcome. And so I've had a number of young people who have had a cannabis-induced psychotic episode after getting a medical cannabis card, or a cannabis-induced manic episode, and who, some of the conversations that I'm having with the young people and their parents are around, can you, are target around the behavior of, can you give that medical cannabis card, back? Can give it to your parents, lock it away, or can we tear it up? Can you sort of cancel that so you're no longer able to so the access is reduced as an intervention. But yeah, it's the regulation is all on the side of, and all leaning, is really leaning towards how do you build up this system of profit-driven cannabis industry, and sort of the safety and regulatory mechanisms really are sort of minimal.
Right. Right. It's kind of like adolescent brain development, you know,
Yeah. Well, and
the
then
immediate reward infrastructure develops first, and then it takes quite a bit longer for the top-down, the prefrontal cortex and top-down loop to develop. Okay, it's one question from an attendee. So for a patient with clear psychiatric conditions prior to initiating cannabis use, who is not motivated to change cannabis use at all, is it best to start with a cannabis use disorder focused treatment or psychiatric treatment geared towards the underlying mental health or comorbid mental health symptoms?
So I'd reference, and I think if my slides are going to be made available, there's the slide on integrated co-occurring substance use and mental health treatment that links to a SAMHSA practice guideline that I sort of was the main driver in editing and writing it. It's important in those situations to be sort of co-targeting both. And how I do that, how I implement that practically is I'm aggressively treating the mental health symptoms while also doing sort of motivational interviewing related to cannabis during each session. And from the what do you focus your psychotherapy on? That's a good question, and actually that's a question that our field, I think, is still reconciling. I think that there's a way to do sort of somewhat of like a transdiagnostic approach of sort of using CBD principles that are sort of co-targeting those depression and cannabis together. But for a young person who's not motivated to do CBT towards cannabis use, what I'll do is I'll do the CBT for depression with them individually, and I'll be aggressively targeting their depression with medication if that's indicated. But I'm also incorporating individual motivational interviewing with them, and I'm also having separate session. It's recommending having parent-only sessions, working with their parents and talking with their parents around how do you set household limits related to cannabis? How can you change like the household rules, the reinforcers to positively reinforce the young people to kind of engage in things that aren't consistent with them using cannabis and to negatively reinforce cannabis use.
Wonderful. I think let's do one last question, and then I think many people need to hop off. Any advice for helpful interventions or strategies to consider within public high school settings?
Public high school settings. So I do some work in school settings, and I think in public high schools, there's a lot of different things that can and should be done. There needs to be education in the public high school setting related to negative health effects of cannabis, and there also needs to be sort of mechanisms within the high school system for both providing prevention, universally within the high school setting, but also for identifying those youth that have a cannabis use or a substance use problem and getting them connected to services, and not doing that in a punitive way. But, if a young person is caught with, vaping cannabis in the bathroom, instead of suspending them, linking that sort of offense to a referral for substance use treatment in the community. There are school-based interventions that have shown some efficacy for treating sort of mild cannabis use, early interventions. One of them is called the teen marijuana checkup or the teen cannabis checkup. That is really a 2 motivational interviewing session model that's done in the school system with the young people. And so there's evidence for that. And then there's evidence for sort of a motivational interviewing plus light CBT across like 3 or 4 sessions. That's called Teen Intervene. That was developed by Ken Winters in University of Minnesota. That's also shown some efficacy.
Wonderful. I'm going to turn over the questions to Dr. Chevalier at this time, and I'm going to leave the Zoom room to attend to a patient group. Thank you again.
Yes, I'm just going to interject really quick. I was able to get this for 1.5 CMEs, so CE credit. So everybody who's stayed on, you guys will get that. So that's great news. And now I'll turn it over to Dr. Chevalier.
Right. I'll just continue with some of the questions we've been getting for you, Dr. Hammond, here. One of the questions was, it sounds like educating parents pertaining to reduction of use would be more beneficial than complete abstinence. Do you agree?
There's a lot of focus on this concept of harm reduction and whether or not reduction of use is helpful. The data on that in young people is less consistent than the data in adults. And the data that cannabis use, even cannabis use that doesn't meet the threshold for disordered use or for having a cannabis use disorder, is clearly associated with adverse health outcomes over time. And so it's based upon those and the sort of the neurodevelopmental effects from the brain findings. It's I think that the messaging clearly does need to be as sort of a primary messaging of abstinence or stopping cannabis is what we recommend and what is best. For youth and for youth that do not respond to that messaging, then I will go to recommending, okay, let's use motivational interviewing to explore the ambivalence. Let's further explore the relationship between the cannabis use and other symptoms. And then with those youth and those parents, I'll work around reduction in amount as a goal. I hope that answers that question. I think the important emphasis point is in this population in particular, because of the developmental sensitivity. It's again, the abstinence is what's associated with the best outcome, and even low levels of cannabis use is associated with poorer health outcomes compared to no cannabis use. But for those youth that are willing to cut down but unwilling to stop, that's a reasonable goal. But I wouldn't jump to that goal immediately first.
Absolutely. Appreciate that. And then we've got one last question for you in the chat here. It's a question about genetics. Have you noticed a weak or strong, if strong, how strong genetic component regarding how likely it is that an adolescent will end up becoming dependent physiologically on cannabinoids? Does this change for individuals who have a first-degree family member? We'll just start with that portion of the question.
Yeah. No, it's an interesting question and a really relevant area of research. Some of the genome-wide association studies that have been conducted in this space, and the sort of mega and meta-analyses across these studies suggest that cannabis use disorder has a moderate heritability, and that there are there are genes that convey risk for developing a cannabis use disorder that track in families, and there's a polygenic risk score, which is really the additive small effects of multiple genes sort of add up to a higher magnitude effect of having a cannabis use disorder in young people. One of the genes that shows the largest signal for developing a cannabis use disorder that's been shown in sort of the largest meta-analysis in this space is the acetylcholine nicotinic receptor 2 gene. And so it speaks to the sort of the intersection between cannabinoid and nicotinic systems and cannabis and tobacco, and sort of how is that a part of this? And so more to come there, but the genetic research to date, at least, does not have a sort of a clinical utility right now, but I think it is going to help inform us developing next stage interventions here, and perhaps helping us better parse out who's at higher risk and how to get them treatment.
So I selfishly have one last question for you, since we got through all the ones there. I'm a true behaviorist at heart and very interested in contingency management and its use. I'm curious how the studies have done it so far with cannabis. When I've listened to other folks talk, it's typically not been something applied to cannabis due to the long duration it's found in the tox screens. And then by the time we send out, for confirmatory testing, it doesn't have that same tightness of association that you'd find with those shorter half-life substances when it's used with cocaine, psychostimulants, things like that. Can you speak a little bit to the pragmatics about contingency management and cannabis? Is this something that only happens when somebody's fully negative and somebody pops back up and then it sits in their system for 2 weeks from a single use? Do they just lose out on all of those, or how is it handled in that situation with cannabis?
Yeah. Well, so I guess so the research that's been done in this space with contingency management, and it's in the adult space. There's a clear, really strong evidence for contingency management for cocaine use disorders and other substance use disorders. In adolescence, it's actually it's one of the stronger spaces of the behavioral literature. Is there's multiple studies replicating this finding that shows that adding contingency management to CBT increases increases abstinence by about 20% in that population. And how those studies have done it, they've all primarily been led by Alan Budney and Kathy Stanger up at Dartmouth. And what they typically will do is they will they'll use a voucher, and they use a point of care qualitative urine drug test for cannabis. I think with the threshold set at 100 nanograms per deciliter, which is sort of the standard quantitative test threshold. And they haven't had this issue of this, of the long half-life of cannabis in the system interfering with those results, especially beyond the first maybe 2 weeks or so. The urine toxicology data actually, it's not a myth, because it's definitely true, but the idea that in a daily user you're going to have a positive urine cannabis toxicology for 3 weeks, or for up to 30 days after abstinence, that is kind of more of a myth. There's inter-individual variation in terms of how quickly that urine cannabis test goes to negative. But it's when a young person comes positive again, I'd be wary of, it's like using once like 3 weeks ago is not going to result in a positive urine cannabis test. And so for contingency management to be effective, you really need that point of care test. You need to have them pee in that cup and you to get that result like 5 minutes later, and then for you to give that reward immediately for that to be effective, and sort of a delay in that makes that sort of untethers those reinforcers and makes that less of a useful intervention to reshape behavior.
Thank you. Well, we so greatly appreciate your time and your expertise sharing us this afternoon/morning. So thank you so much for coming. And please, everybody else, remember, you'll get your messages regarding the CME or CE certificates. You can certainly email Tammy